move to try and tackle this title that I've been given and has set me so much thought. As we move it forward, how do we move this thing forward? There we go. My disclosures are there. I'm mostly going to be talking about the direct trial, not entirely. The drug companies do have me on some of their listings. They don't know what to make of me, but they keep me there to try and keep me quiet. And I will also point out that all the slides from Direct, the whole lot from all our presentations, are up on the website here. You can use them, you can borrow them, and you can argue about them later. So you don't need to photograph most of the slides. I don't need to recap the first talk of this morning. Diabetes, we now know, is the most tragic disease. When I was a student, I was taught that this was mild diabetes. And I remember the lectures. Oh, there's some sugar in your urine. Usually the nurse, not even the GP, tested the urine and finds some sugar. Don't worry, it's mild diabetes. You can take a pill and come back in a year's time. And that was how we managed it. That really was how we managed it, mainly, not entirely. And yet it was considered permanent, incurable, and progressive. So there's this kind of disconnect here. We treat it as mild. Now we know it's not mild at all. It is the most tragic disease. It shortens lives, and it shortens them painfully with multiple disabilities. And we have done a disservice to our patients with diabetes by not telling them that. We've already seen this slide, and I don't need to do it in detail. I just put a line here at the age 55, which used to be the average age of diagnosis in the UK. I think it's down to about 51 or 52 now, at which point you're losing 5 or 6 years of life, painfully and with disabilities. That is despite our guidelines. These are big European studies where we have guidelines. They're slightly different between different countries, but they're all doing their level best to apply our treatments with a target of a hemoglobin A1C of 7%. Is that the target you would like to be if you had type 2 diabetes? Or your mother, not necessarily your mother-in-law? I don't know. But it's not what I'd like to be. And just as a backdrop to this, this is a fabulously valuable drug for the industry. Last year, 488 different drugs, that's 70 generic compounds, approved, licensed, trialed to reduce hemoglobin A1C by a maximum of about 1%, as you've heard. That's how valuable the disease is. Now, the title I've been given is to do with whether it's hemoglobin A1C or blood pressure. And of course, this was a topic that raised its head during the UK PDS, and I was involved in that the original presentation on blood pressure in the UK PDS, as to whether it was more important to lower the hemoglobin A1C or more important to tackle the blood pressure, which is so commonly elevated, because, as we know now, the disease process that drives type 2 diabetes is the same disease process that is driving high blood pressure and the rest of metabolic syndrome. Now this, I looked for some nice data which began to tell us which might be valuable. And this is from this enormous Swedish study, over 250,000 people with diabetes in the registry compared to over 1 million non-diabetic. And what it tells us, if you run through these panels, top left, death from any cause, glycated hemoglobin as you go up clearly increases the hazard ratio for mortality, as does blood pressure, a little bit more weakly here. And you can look at acute myocardial infarction, same sort of pattern, or stroke, or heart failure. And it's hard to say that one is more important than the other in this, but clearly both are going to be important, and there may well be interactions between them. And I think you really can't separate the two, because these are essentially part of the same disease process, and that's probably where I've come to in my thinking. If you keep your hemoglobin A1C, and you're Caucasian, perhaps if you're Asian you have to even learn this, but if you keep it at 21 or 22, you will not get type 2 diabetes. It's just almost impossible, even when you get to be an advanced age. As soon as it goes up to 22, 23, 24, we know the relative risks are increasing, and you've heard the concern about a relative risk of 2 from the cardiological perspective earlier today. Well, a relative risk of 2 is already there with a BMI of 22 or 23. And by the time BMI is 25, your risk of diabetes is up 8-fold. And these are crazy relative risks. This is an association which can only be causal. This is not a comorbidity. This is a causal relationship. And I think we have to bear that strongly in mind. And you can do the same thing for blood pressure. And here it is done by Arya Sharma and one of his colleagues here. And this one, what this one shows is groups by body mass index category, and the prevalence of diagnosed hypertension in both men and women, and they're pretty much the same. You can put a line here at the prevalence of diabetes in people who are not overweight, and you can see that that prevalence leaps up with the body mass index above 25, and again and again. The mean BMI in the population around about 30, 29 or 30 in North America now. So most people now are it's going to the point where roughly 50% of the population are hypertensive because of their overweight and their obesity. Can we do anything about it, and what can we do with let's say, diet and lifestyle for the present purposes? If people lose weight, and you can see here over the period of years, there's a change of weight here which can be achieved in look ahead. There's a change in hemoglobin A1C which follows that very accurately, and there's a similar change. The same pattern is seen for systolic blood pressure. So clearly, if we agree that being overweight is driving high blood pressure and hemoglobin A1C, taking the overweight away, and this is a weight loss of about a mean of 8 years at the beginning, with regain up to 8% at the beginning, regaining to about 4% in 4 years, having quite profound effects on hemoglobin A1C and on blood pressure, more than most antihypertensive drugs, at least to begin with. And in the look ahead trial, this is the biggest, most expensive trial ever conducted in type 2 diabetes, which completely dwarfs anything we've ever done this side of the Atlantic. The primary outcome was going to be, does it have an effect on cardiovascular outcomes? And the answer was, no, it didn't. And the trial was stopped early because it didn't. There are many reasons for that, one of which being that their average duration of diabetes was 8 years. So most of these patients had quite well-advanced diabetes too late in the disease process. On the other hand, when it was analysed by Ed Gregg later, it was clear that those patients who lost weight, remember the mean weight loss was 8%, when those who lost more than 10% or 10 kilograms, the same, cardiovascular events were reduced and mortality reduced by about 20%. So clearly, weight loss of the order we were achieving with 4 to 8% is not dealing the outcome we'd like, but a much more marked weight loss clearly is. And that weight loss we can look at from the point of view of the diabetic. These were all patients with type 2 diabetes, and their mean weight loss was 8 kilograms at 1 year, as we said before, dropping to 4 kilograms. They had remissions of diabetes of 11%. So at the beginning here, and these remissions remained at 8%. So these were people who are no longer diabetic. And this was not the primary outcome of look ahead, but it's telling us that weight loss can have huge benefits for people who are hypertensive or who are diabetic. And remember, once somebody's remission of diabetes, they're no longer diabetic. They no longer have to declare diabetes on their mortgage applications, on their life assurance premiums. They don't have to pay extra insurance costs to take their grandchildren to Florida if they're mad enough to want to go to Florida. It's a big thing not to be diabetic. And this was one of the first studies to report remissions with a non-surgical approach. The surgeons have been saying they could do it forever. We went back and looked at a study which was published a very long time ago from Aberdeen, not represented in today's meeting, further north. And we looked again at the years of life lost here in people who were overweight, BMI over 25, with type 2 diabetes. And that was in the days when all the patients with diabetes went to one clinic and they were followed up until they died. And so we had very good records going up to death. And we could look at their weight losses when they saw the dietitians. All the patients saw the dietitians at every visit, and they came usually twice a year, sometimes 3 or 4 times a year. And if they lost no weight in the first year, the dietitians had not done their job, or the patients had not done what they were told to do, they lost about 7 years of life, just much the same as we've heard from more recent studies. If they lost, and we were interested then in whether they could, what would be the benefit of losing 5% of body weight, because that's what our dietitians usually could manage to do. They were living 2 or 3 years longer. And so we didn't sack the dietitians, we kept them. I've looked at those data again, and if you take it up to the end of where our data took us, up to 14, 15 kilograms, at that point, these patients who lost that amount of weight lived the same length of time as people who'd never had diabetes. So this is suggesting again that much more major weight loss, which is potentially achievable by a non-surgical route, is what might be to the benefit of our patients, to take them out of the category of diabetes and its risks. Now that led us to start developing dietary programs in Scotland. We spent 10 years developing a program which is now commercially available called Counterweight-Plus. And essentially this, I'll explain this in detail, has a weight loss phase using a formula diet. And that was because our patients felt it easier and found it easier to follow the soups and shakes, a formula diet, for a period of weight loss, followed by a weight maintenance program, and it was all integrated. And the approach we took was to say to our patients, or started saying to our patients, you have type 2 diabetes, we want you to take a much more serious approach to this. If you had breast cancer, your 10-year survival would be 80% on average. If you had non-Hodgkin's lymphoma, your 10-year survival on average is about 60%. These are current figures from CR UK. With type 2 diabetes, that Swedish study tells us your 10-year survival is about 50 to 60%. So rather less than non-Hodgkin's and way less than breast cancer. If you had a cancer, you would be offered chemotherapy. You'd have 3 months of quite serious treatment. Your hair will come out. Everything else will come out. Will you take the chemotherapy for your cancer to get a remission? And I think all your patients would say yes. Now, we're saying to our patients with type 2 diabetes, we need to treat this equally seriously. Its outlook is similar to a cancer, but the treatment is a diet, and here it is. That was the basis for this, and multiple applications to get this funded through Diabetes UK, through NHR, were unfunded. And if any of you were on the panels, don't worry, we got there in the end, thanks to Diabetes UK. And what they did was to put together my applications in Scotland for basically a realistic primary care-based intervention to try to turn around type 2 diabetes, together with Roy Taylor's work in Newcastle. He had done a pilot study, very small study, 11 patients, to look at 15 kilograms weight loss and to show that, firstly, the patients became non-diabetic quite quickly, and secondly, that appeared to be driven by the loss of ectopic fat, which we know is the intra-abdominal fat, the fat which had gathered in their livers and in their pancreas. So Diabetes UK put us together and said, do the job properly. It'll be a major primary care-based trial with a subset in the north of England who will do the detailed scanning, imaging studies and metabolic studies to look at the mechanisms behind remission of diabetes if we can achieve it. And this is quite nice for me because Roy Taylor and I both qualified at the same time. We started our careers on the same day in the same hospital, and we've been great friends ever since. So there you go. We recruited primary cares. Some of you may be from outside Islington. I don't know. Are you? A few of you. Here they are, primary care centres. The control group were asked simply to recruit patients who would then be followed up. They had to do nothing. They were using guidelines, signed in Scotland and poor old nice in England. In the intervention group, they had the same guidelines. They were followed up in the same way. We had permissions to collect data from everybody who dropped out of the program. But in the intervention group, they had a program which I'll explain. We went to primary care now. We have research, primary care practices in Scotland and in North of England who have volunteered to help with research. They're quite busy because they're doing other programs. Normally, a 5% response rate from primary care is considered quite good recruitment for research. They're difficult trials. You have to turn up on the right day and you can't have holidays and things in between. We got 28% when we went to overweight people with type 2 diabetes and said, would you like a go at turning this disease around? A very high response rate. They were very ordinary patients with type 2 diabetes. I'll point out that we only recruited patients up to 6 years, not because the intervention doesn't work beyond 6 years, but because we want to give it the best possible shot, and the 6-year window we thought was okay. We did not include patients in insulin because our GPs said, look, for the first attempt at this, we don't want to have to guddle around with insulin doses, not because it doesn't work for people who are already on insulin, but it's probably less likely. And their average hemoglobin A1C 59, BMI 35, and average age 54, which means their diagnosis was on average about 51, age 51. They were seen in primary care only by practice nurses or dietitians, if there was one, and that was broke down into the north of England, where they were seen actually entirely by practice nurses, whereas in Scotland we mostly had dietitians who went to the practices and could deliver the intervention. And the intervention was this. On day one, we said, stop all your anti-diabetes medications, all of them on day one, because we do not want any hypoglycemia. And also, we want to seed this idea that you potentially can become non-diabetic, and if you don't stop them, you will not be non-diabetic. You can't show if you're still taking the medication. That isn't non-diabetic. That would not be a remission. And we asked them to stop their antihypertensive medications and diuretics, all of them. And the reason for that is that if patients were to go onto this program and then go into rapid weight loss, remaining on antihypertensive medications, we would see postural hypertension, fractured hips, banged heads, and we're seeing this every day in my general medical ward from patients who stop eating for one, usually because they're ill or they're just not eating for one reason or another and remain on their medication. So we didn't want postural hypotension. And added to which the patients were quite keen to see if they could do without. They went on to then, we're changing terminology here. In fact, the word remission of diabetes is quite new for most of us. We have to get used to saying it, so then we can go for it. Total diet replacement. That means they don't go to eat with their families, they don't go to a restaurant, they don't have a cappuccino or a latte or a glass of wine or any of the nice things that they have, their normal up to then diet has been doing. We take them through this for about 12 weeks whilst priming them for food reintroduction meal by meal, and that was the phase that they found most threatening, most difficult, and needed support during reintroduction, meal by meal, and on to weight loss maintenance. And that was the shape of this program, up to initially 2 years, although it's now been extended up to 5 years, with very minor support for the final phase. They're just seen every 3 months. The diet program was pretty much the same as any other commercial total diet replacement. It was replete in all micronutrients, so safe. It had 830 calories, so you can calculate their weight losses, and we know that by 12 weeks they should achieve at least 15, and most of them would get 20 kilograms weight loss if they did it completely. And these are the nutrient breakdowns. It has to be like this to make it palatable. It doesn't really matter what the exact breakdown is if you're only giving 830 calories. Then the food, only at that point did we ask them to increase physical activity. Why? Because these are people with BMI, an average BMI of 35. They cannot take more. They're already working hard to get about, and to try and ask them to take more activity simply doesn't work, and it also distracts them from the target of losing weight. So at that point we said, see if you can increase physical activity. We gave them guidelines with a program developed by Diabetes UK. Before going on to weight loss and maintenance, and I'll point out here, this is a food-based diet. This is returning to eating food with their families and with their friends, but they have to change what has been normal for the last 20, 30, 40 years of their lives, changing to a new normality. And that was why reintroducing meal by meal is quite tricky. We had a notional target of approximately 50% of calories from carbohydrate, which is not high, it is not low, it is normal for Scotland and the North of England. So we didn't want to ask these people to stand out and do something radical. We're well aware that some would like low carbohydrate diets and some would like high, and there's evidence to show benefit with both. Randomized trials, and there have been many of them, and many meta-analyses have tried to compare giving high or low carbohydrate diets, and there is no difference. No difference for weight change, for hemoglobin A1C, for blood pressure, or for lipids. And that is the evidence, and I don't want to have to go into it in any detail, whoever asked the question at the back. However, there are some patients who passion drives them to say, I want to do the low-carb thing. Fair enough, we accommodated them, allowed them to do that, and didn't force them in either direction. Importantly, they were offered weight management of relapses, so if their weight went up by more than 2 kilograms, we offered a short period back on the soups and the shakes to get them back on target, but only once. They had to learn from that. So on we go. We had a protocol, of course, to reintroduce medication if needed. The design of the study was this. We assumed that people with type 2 diabetes, about 5% in our control group at the end of a year, might be non-diabetic. Guesswork, but from the evidence from control groups elsewhere. We aimed to get a 22% remission rate. That was considered by most of the referees as extremely high and improbable. And that was why we were turned down for funding on a number of occasions. Why 22? Firstly, because the public health people said if you can get 1 in 5 people with type 2 diabetes to be not diabetic, then we'll have to look at our policies and strategy. 1 in 5 would be a huge, huge achievement. Secondly, Look Ahead got 11% in North America. In Scotland, we can always do twice as well as any American. So we aim for 22%. And the results, many of you have already seen this. They staggered us, they staggered everybody. At 1 year, the control group was pretty much as expected, 4%, 3% at 2 years. 1 year, we had 46% of our patients no longer diabetic. They were not receiving medication, and their hemoglobin A1C was out of the diabetes range. And that certainly has changed things. And that figure has fallen at 2 years, and we've published the 2-year data earlier this year. And I can tell you now that the reason for that decline is entirely due to weight regain. So the people who had remission at 1 year and then no longer diabetic at 2 years had regained about 7 or 8 kilograms. So it was a relatively small number who regained a lot of weight. Those who maintained their weights did pretty well. So those are the figures that sort of stole some of the headlines. That was the regain of weight. This is a slide which has not been, this is not actually published yet, so probably don't take a photograph of this one until we've got it out. We're hoping to submit it this week. And this shows the results by weight change in the intervention group. We've previously published the two groups combined. And what that showed was that there were differences I'll explain. So in the intervention group, these are people who were given our program, all of them. Those who lost less than 5 kilograms didn't do very well, but about 5 or 10, just a bit more than the control group, were in remission at 1 and 2 years. 5 to 10 kilograms weight loss, our old sort of target, actually was pretty good. 40% were no longer diabetic, off medication at 1 year and 2 years. But then the figure which has been published previously, if they lost the 15 kilograms of weight, or 15%, it comes to the same thing, 86%, nearly 9 out of 10, no longer diabetic at 1 year. And those people who remained 15 kilograms before baseline, 82% at 2 years. So essentially, there's virtually no change. So what it's telling us is if you can achieve this major weight change with a very well-designed diet and support, that remission rate is actually incredibly well maintained for at least 2 years. We haven't yet analysed the 3 years, although they are now complete, but we will do that at a later stage once we've got a bit further follow-up. So that's the message. I can show you some just headlines out of the secondary outcomes. Firstly, hemoglobin A1C was reduced here in our intervention group, whereas it rose in the controls, despite fewer patients being on medication. This doesn't look at the doses or numbers of medication, just numbers of patients on medication, whereas it increased in the control group. Similarly, blood pressure was lower, fell more in the intervention group, and then didn't fall in the controls, despite fewer being on antihypertensive medications at 2 years. But about half of our patients did require to go back onto antihypertensive medications by the 2-year phase. Not necessarily the same number of drugs or doses, that is still under analysis at the moment, but fewer back on it. And all these things contribute to benefits for cost. Cardiovascular risks in our patients who achieved remission, this is just the patients who went into remission, at baseline, their Q risk was 16% 10-year risk, which puts them in the high category. Their hemoglobin A1C, 57 millimoles per mole. At 2 years, their Q risk was 8.2% with a hemoglobin A1C of 40, so down into the not even pre-diabetic range on average for these patients. A benefit. Their quality of, they had, this is, I probably shouldn't show this, it's a very small numbers, and I'm not pinning my career prospects on this being maintained, but with these benefits, we should be seeing fewer cardiovascular risks. If the hypothesis is to take diabetes away, we'll take away the complications. We didn't expect anything at 1 year, and there wasn't any change at 1 year. However, in the second year, there was actually a significantly greater number of serious adverse events in the control group than intervention, and you can see that they are falling into the pattern that you might expect for people who continue to have their type 2 diabetes compared to the smaller numbers in the intervention group. So we'll see if that progresses as time. The study was not designed with power to analyse that. Quality of life improved. If any of you have ever lost 5 kilograms in weight, you'll know that was jolly hard work. It's actually very hard work to lose 5 kilograms in weight. Do you feel better? Does everybody congratulate you forevermore? Does quality of life get? No, it doesn't. Sadly, they tend to say, well, that wasn't really worth it. We'll put the weight. It was more fun eating. However, my job, by the way, in this talk is to keep you from your lunch as long as I possibly can. And I'm doing a pretty good job so far. I'm keeping an eye on that clock up there. Quality of life with 10 or 15 kilograms of weight loss actually does get better. And the testimonials, and we've had patients from the trial who've spoken, brought tears to our eyes by saying, look, I've got a life back. My wife's prepared to go out with me again. I can go dancing. I'm no longer diabetic. It's a fantastic thing. So that was a benefit. And then the cost. Now, the average cost, these are published figures, of people with type 2 diabetes in the UK, in the NHS, and I think this is from England, not Scotland. Somebody may correct me, but they're not very different. This is the average. The cheap years at the beginning when you give them metformin and wonder if that's doing any good. The expensive years when they've got their complications at the end. The average is £2,800 a year, every year. And that is retrospective, it's probably not including some of the more expensive drugs that we've heard about. The total cost for our patients in the intervention group of the DIRECT trial, this includes the cost of delivering the program, the soups and shakes, the time given by the nurse, the dietitian, a little bit of time from GPs, not much, all their admissions to hospital if they had them, all their referrals to outpatients if they had them. The total cost of everything added up was £982 in the first year, and in the second, putting the 2 years together, it was £1,400, so it works out at £700, just over £700 a year to go into this program and be followed up for 2 years, exactly as we did within the program. So we're beginning to ask, why are we continuing to do this one? And that's a real question, and I think it's something we're all going to have to face. To actually switch patients towards, to open at the moment you have a door which says diabetes continuing to deteriorate, and your patients go there every few weeks or months. We're suggesting you turn that sign around to say diabetes in remission, and it's going to cost the NHS a good deal less if this is anything to go by. The question is, how do we shift resources to do that? And that is perhaps for a discussion at another time. Now, Roy Taylor has been very quiet during this presentation, and he's still quiet, but I'll do his talk for him now. Basically, at baseline, our patients had a very nearly absent first phase. Their beta cells were not producing insulin when given intravenous glucose, and that's what that shows there. Those who did not achieve a remission stayed absolutely flat up to 2 years. Those who got remissions, they were responders, had a rapid improvement in first phase insulin with their weight loss, exactly as he showed in his very small Newcastle study. And that was maintained for 2 years without any decline. So if they're going to recover their beta cells function, it happens quite quickly, and there it is, but not to normal level. And that is probably because these are people with the genetic, epigenetic background of metabolic syndrome, and we know that the offspring of people with type 2 diabetes have impaired first phase. So they've probably gone back to their pre-diabetic first phase insulin response. Their total insulin capacity, their response when given intravenous glucose plus arginine to stimulate it, increased more gradually and became absolutely normal, same as non-diabetic people at 1 year, and remained there for 2 years in those who achieve remission. So there's a capacity for the beta cells to regenerate their full capacity in those who are going to get remissions, but not in those who remained diabetic. And so we're now asking big questions as to what is happening in the beta cell to allow some to recover and others not. And part of the answer is here. At baseline, our patients all had high liver fat, and this was measured by MRI. They had a very high liver fat. That fell very substantially to normal levels in those who got remissions. But in those who didn't respond or had relapses, it didn't fall. So they remained with fatty livers. Their VLDL with the fatty liver was high. The VLDL secretion fell in the patients who responded, but actually went up in those who were having relapses of their diabetes. And the VLD increasing puts fat into the pancreas. Pancreas fat was high with type 2 diabetes. It fell dramatically in those who became non-diabetic, but it did not fall in those who failed to respond or in those who had relapses. And one of the tantalizing suggestions here is that this may be to do with the fact that the VLDL palmitic acid, is high in those who had relapses, but low in those with responses. Now, palmitate, and this is a complicated story, is a fat made by de novo lipogenesis. It's made in the body when we are overfed with carbohydrate, and there's a story here. We make excess palmitate, and palmitate was shown by Anne Clark in Oxford some years ago to be toxic to beta cells. So it's possible that if you want to lose weight, it doesn't matter if it's a high or low carbohydrate diet. If you want to keep your weight steady, it doesn't matter if it's a high or low carbohydrate. If you're going to gain weight, don't do it with a high carbohydrate diet, I think is the message here, until we know better. And this now, I can take a sort of conclusion. This is my conclusion. We now know what type 2 diabetes is. It is not an endocrine disease. It is a nutritional disease, and it is very simple. It is obesity in people who are genetically, epigenetically predisposed to metabolic syndrome. So what happens is you consume more calories than you need. You store them firstly in your huggable, squeezable bits of adipose tissue. That gets overfilled at a certain point to put fat into the liver, and then the liver doesn't function well, and it puts out excess glucose. It transports fat into the muscle. The muscle doesn't function very well, and that includes heart muscle, to reduce its capacity to take up glucose. And it exports, as we now discover, into the pancreas. And the pancreas doesn't function well. The beta cells don't work when we put extra fat into it. It doesn't make insulin. But And this is, we're talking now about each one of you probably has a personal fat threshold. If you gain weight, there will come a point where you start putting fat into ectopic sites, and that threshold probably reduces with age, and it's lower in Asian people. But that process is reversible. And that's the big message here. It is a reversible process. And I'll just fly through this. Already, within a year of publishing our data, England has announced funding, and they're starting in April, and some of you may well be involved in this, to put people into a large-scale diabetes remission service evaluation. And some CCGs have already started this, not waiting for that. Why? Because their patients are demanding it. And that's one of the exciting things, perhaps slightly through Diabetes UK, but the patients themselves wanting this. In Scotland, all our health boards are now trained up to be able to use the evidence-based Counterweight-Plus program. This may not be the end. You know, there may be better programs found. This is the one which currently has the evidence base, and that is what we're going to be using in Scotland to make sure that we give something which we know should work first time round. The ADA and the EASD have now agreed that remission of diabetes is a valid target for treatment, and they've even agreed on the criteria for remission, which is a great relief to us all. And I've been now personally involved in trials, setting up trials in all sorts of different countries, fascinating problems with type 2 diabetes in countries where we don't have, and I'll just mention Nepal in particular, and there it is. In Nepal, there is no primary care. People can't afford any of our new drugs. They do get given metformin if they happen to be able to attend a hospital or afford to get there, and most of them can't. It is a tragic disease, ruining families and communities. And I was approached by a community empowerment charity to say, we've read about your research, come and help our communities? And the answer is, yeah, we'll do it without drugs and without doctors and without anybody else, using a diet based on the famous no doubts diet, the Scottish tongue-in-cheek diet, if you like, 830 calories a day, which uses porridge, followed by lentil soup, followed by more lentil soup. And okay, we've worked out the nutrients, and if you want to lose weight and can do it, that's another way of doing it. So there are valid ways of doing it. That is where I've got to. Thank you very much. If you were asleep through this, the end of the story is obesity is the same as type 2 diabetes in susceptible people, and it's reversible. And there's a huge thank you, especially to Diabetes UK, who did this with donations from ordinary people and families of people with diabetes, not with any government money or anybody else's money.